So the theme for our panel discussion today is how can we support people with dementia at the end of their life? But to start, in terms of leading causes of death in Australia, as Aaron highlighted, in the last few weeks we have learned that Australia is now the leading #1 cause of death in Australia. And that used to be the second leading cause, with the leading cause for death of women in Australia prior to that knowledge that we gained a couple of weeks ago. Cancer as a life-limiting diagnosis came in at 4th, with lung cancer in particular being the most significant cause. Now, when I think about the palliative care teams that I've worked with, at least 50 to 60% of the patients I have books have a cancer diagnosis. Probably around 20 to 30% of patients have had a diagnosis for chronic disease, whether that's chronic heart failure or COPD. I would say with all the palliative care teams that I've worked with historically, less than 5% of patients that have received palliative care support from the teams that I've worked with have had a dementia diagnosis. This is sadly reflected in national and international data for palliative care as a specialty. While dementia is one of our leading causes of death, it is severely underrepresented in terms of people receiving specialist palliative care support. Dr. Aaron Wong, is the palliative care community failing to address the unique needs for those who are approaching the end of their lives due to a dementia diagnosis?
Wow, that's a tough first one to start off with. I think the first thing to say is the statistics are very daunting. Dementia is it's a problem of very sizable proportions. Something around in 40 years' time, we'll be seeing more than 1 million people living with dementia in Australia, and that's immensely confronting, both from a public health issue to systems at every level, from care in the community to healthcare in hospitals as well. The other issue I think we have, Steve, is that not have people that we work with and care for touched by dementia. Remember the data I showed you that dementia is a common comorbidity among people who are older. So I think we under-recognize it, we under-diagnose it, and as such, it's really hard to imagine how we're caring in the most effective and optimal way for people. I think because of the scope of the problem, much like what aged care should be, palliative care should really be core business for everyone. And I think there's so much more we need to do, a lot of work we need to do, and we can only do that by working together collaboratively between dementia care sectors, aged care and palliative care. We need to learn from each other, and most importantly, we need to partner with the people that matter most, which is the people living with dementia and their caregivers and families.
What really strikes me about your answer there, Aaron, is the conversation between disciplines too. Maybe we need more Jerry palliative qualifications, but also like just that conversation between palliative care and aged care too. Like I think we as a palliative care community could do a lot more deliberate engagement into residential aged care. Because I think we've got a lot to learn too about, the individualised care that, patient care assistants, the enrolled nurses, the registered nurses provide as well too. And we won't be able to do that co-learning unless we have the conversation and the exposure. I asked my friend ChatGPT to look up the Oxford textbook of palliative medicine to see how often it mentioned dementia as compared to cancer or chronic disease. There were over 3,000 references to cancer, approximately 400 references to chronic disease, but dementia is only mentioned approximately 100 times. I'm going to turn this to Sarah Bascom. Is part of our problem a lack of dementia-specific research in palliative care and also resources, including education resources, that speak specifically about the uniqueness of dementia in the context of palliative care too?
Yes, is the short answer to that, Steve. There is a huge lack of research. you may have picked up from my little bio there that I'm usually the one that's behind the scenes supporting the researchers to do their thing. So this is not my comfort zone being the one on the Q&A panel. I'm usually the one behind the scenes. So I have just made a couple of points that I want to make sure I cover. So if I'm looking down, that's why. I think there's a couple of reasons why there's a lack of research in this area. I think research in vulnerable populations and where consent is challenging does deter a lot of people. I've worked in research ethics for a lot of my life and in hospitals, including the Royal Melbourne. And if you look at the number of applications that we got from the more medicalised areas compared to ICU, for example, where consent is an issue, the numbers were much, much less. And the time and the difficulty getting it through the ethics committee really did slow that type of research down. So I think that's one aspect. I think that's a reason. I don't think that's an excuse. You know, we can do hard things. It doesn't mean we shouldn't do it. It just does mean it sometimes requires a bit more effort. And I think, and this is not just a problem in Australia, but generally the way that research is funded, it's often very short-sighted. You might get a research that's funded for 1, 3, maybe 5 years if you're lucky, but a problem this big affecting community, the whole of the population, this is a much bigger problem and really requires, you know, that really vision and strategic foresight that governments aren't necessarily great at doing. They look at, you know, how long's a government term, but something like this is going to go over, you know, many government terms. And so that requires a bit of bravery as well, I think, from policymakers. So I think that's a part of it. And then, of course, the lack of resources, research means there's a lack of resources for both informal and formal carers, so the community as well as the workforce. My boss, so the academic lead of the 2 projects that I look after, conveniently did a project a few years ago. She looked at participants who went through the Understanding Dementia MOOC in one particular time point, and she actually asked them, what does palliative care mean in dementia? It was a few years ago now, but I imagine the findings are similar. And not necessarily specific to dementia perhaps, but things like, you know, talking about palliative care means that you've given up on the person. So people were quite reluctant to actually have the conversation to begin with. And also the challenges with the prognosis of dementia. It's very hard to plan ahead because you're not sure how long that person might have. And I think that's, you know, I'll always come back to education, providing education, not just for the formal workforce like people here, but also resources for the community. So there is a lot to do. There was an announcement only, I think, a week or 2 ago from Hammond Care that many of you might have seen. So Hammond Care's been around in dementia care, both as a provider and they do a lot of research as well. So they've just launched/announced a new initiative called Hammond Innovations, and they're bringing together the Dementia Centre, the Palliative Care Centre, and the Positive Ageing Centre. So they are, you know, really starting that conversation about what you're saying. It's not dementia care and palliative care. They need to actually be part of the same conversation and the same pathway. They're just in their infancy. They're actually calling out for researchers and ideas. So who better than the people in this room to really think about what are the challenges that you see? You know, give it a Google, send in your ideas.
Great, thank you. And, you know, I think, you know, looking at some of the resource tables around here today and, you know, the emerging resources that are there for, you know, people at the coalface and so forth. Tiffany Button, I'd like to ask you, as someone who began in direct care roles and now works at that system level, how can we bridge that gap between, you know, some of these resources and the policy guidance, and then actually, you know, equating that to actual practice, you know, delivery of practice and delivering compassionate person-centred dementia care?
It is a good question and a bit loaded. I must say it is a bit of a weedy one because I do remember my baby nurse days where there were ample resources around and I couldn't tell you what a single one of them were. The value of resources are the people sharing them and how much they understand them and value them themselves. I think that tackling it's more than just the resource development. It has to kind of be on different layers of system change. I think from our top policy end, we need our politicians to be aware of these issues, to be invested, to fund them, and to share them onto the agenda in our overall health policy. From our organisational levels, again, it comes down to what resourcing do we put into the services? Do we have enough support to integrate palliative care, aged care together? And how do we do that with our dementia specialists, and how do we actually put in place models where they can work together? From the coalface, where I'm sure many of you are actually working as clinical care coordinators, RNs, ENs, like personal care workers, I think you still have quite a powerful impact. I know when you were sharing the story earlier, Aaron, about the patient living with dementia, it took me right back to a patient I had cared for. And I'm sure everybody, as they were listening, has that one person they cared for in their head. They're like, oh yeah, I remember when that happened to blah, blah, blah. And I think that that's where we really have that ability to take the step forward. It's not just picking up the booklet today, putting it on the shelf and getting dust. It goes down to, well, can I go back to my service? Do we know how to have supported decision-making conversations? So not just conversations about advanced care planning with substitute decision makers, can you tick a box? Yes. How do we empower the older person living with dementia to be a part of that conversation? And if we don't know how to do it or we're not comfortable, where can we turn to for help? So as Sarah mentioned, there are programs available. Hammond Care, for one example, have the Advanced Project, all about how to have an advanced care planning conversation as a supported decision-making conversation, including the older person. There are so many resources from the Wicking Trust alone about education for aged care services on how to handle people with complex palliative care symptoms and dementia. But it's only as good as the amount of time and effort and energy we put into investing in these programs and participating in them. I am very heartened when I attend events like this because you guys are already the converted. You're already here, you're already wanting to learn more. Take it forward, champion it in your services.
Fantastic. So there we are. The onus is on you. You've got to take it back. Peter Norton, Aaron was talking this morning very eloquently about meeting a person at their heart, and at the core of who that person is. In your role with LGBTQI Australia, what systematic or policy changes would you advocate for to strengthen support for people with dementia from diverse backgrounds, and often potentially also historically marginalised backgrounds too, as they approach the end of life?
First, thank you. Being not from a clinical background, I'm probably feeling a bit underqualified in terms of my peers, but in my experience with the LGBTQI+ sector, there can be some reluctance to disclose their identity at that vulnerable age because of lived experience and systemic reasons. And so to go back to that framework of human-centred, person-centred care, really understanding the lived experience of that person, and then recognising that family can be different, it may look different for someone from a rainbow community, and bridging that awareness to accommodate that diversity in a palliative setting. The other thing that sort of I think centres my practice, and it's true I think for a lot of our community, is creativity and how palliative care is about living as well as you possibly can for as long as you can in that sense. So engaging with creative practice, whatever that looks like for the person, and I connect that not just to dexterity but also music and movement and all the senses of touch and smell. Where you can really keep those neural pathways active right to the very end with the right support. And the other part in terms of, I guess, my personal experience in this area is creating that, it was mentioned earlier that the disease lives on after the death of the person suffering from dementia. So creating moments of connection for loved ones in a creative space in that period. So one example, I had a resident with a neurodiverse daughter, adult daughter, and we were able to sort of plan a creative project that started while the mother was still well enough to engage, and then when the mother wasn't well enough to engage, there was a lovely peaceful connectivity with eye contact and touch that they were still able to continue with that. It was a drawing exercise of plants. So they kept drawing the plants and kept refining the plants. So the daughter ended up with a beautiful documented visual diary of those weeks, which I think was a really lovely gift for her. And I think with creative practice, there's a secondary ripple effect, because if you're sitting next to someone who's relaxed and enjoying drawing, you also relax. You know, there's just this sort of extra. So I really noticed that the mother, while she was non-verbal, she was still very comfortable while her daughter was continuing with that drawing program. So, you know, like what we're hearing a lot today, no two cases are the same, so being holistic and being sensitive. But for our community especially, there can be a lot of isolation once a person is in a heteronormative environment where they're assumed to have had children and have had a conventional marriage, etc. And so visually, anything that helps them express who they are in their environment is also worth exploring as well.
Great. And so I think one of the essential, sort of clinical tools, and even, just personal connectiveness tools, I think, in our tool belt then is curiosity.
Yep.
Just learning about the person's history and what their likes, dislikes, what
Yep.
their dreams, hopes, goals, desires, and loves.
Yes.
What are all about. Yeah.
Totally.
Great. I'm going to try and open it up to the floor. Feel free to put up your hand, whether you want to direct the questions to a particular member of the panel or to all the members of the panel. Feel comfortable to raise your hand. I believe Rose is out there with a roving mic. I'll just leave that open, and while Rose is looking around and seeing if any hands are up, I will look at some of our online questions that have come through.
Yeah, we might remove some of these.
Yeah, I'm just going to give it a few seconds, just if any hands up. No. There we are.
There's a lot of mix, so I've left this one because it's the first one with a thumbs up, so clearly you put it, yeah.
Good afternoon, everyone. Aaron's graphs this morning from data diagnosis to death, with all the variables within them, were utterly fascinating, and things that I would like to have a bit free and have a look at myself. But one of the most striking aspects of the recent Oceanic Palliative Care Conference in Brisbane was the emergence of discussion from both practitioners and academics and of all sorts of levels about a conversation between palliative care and voluntary assisted dying. And the other element in the room is at what stage will dementia enter into that creative conversation?
Anybody like to delve into that curly question?
I was hoping one of you guys might.
So,
You want to go first, yeah?
Maybe, so we actually get asked a lot at Palliative Care Victoria about voluntary assisted dying. We do like to stress that the two are not interchangeable concepts. They are complementary to one another, and some people, for their own reasons, choose voluntary assisted dying as part of their palliative care pathway, and that is part of person-centred care. We do draw the lines at people who don't think they will enjoy experiences in aged care services, are scared of getting older, are scared of a level of care that's not acceptable to them, and then see voluntary assisted dying as the only way out, because that is utterly heartbreaking and we should be able to do better. The conversations around dementia and voluntary assisted dying are taking place, I can assure you. In communities near you, it is a conversation piece. It is in its infancy, and I think we still have a lot of way to go on other areas of the voluntary assisted dying legislation before we can really tackle that can of worms effectively.
Yeah, thanks, Stephanie. I think on a practical level, ethically, it's very complex, I must say. Personally, when I talk to patients and their families and hear various expressions of wish to hasten death, I think there is an issue with both advanced care planning, and that's no disrespect to our colleagues who are here today. I think where advanced care planning and indeed voluntary assisted dying falls down is that it's really hard for us as individuals to imagine a state of being, of having dementia at some point in the future. There's this concept called a projection bias, where you picture yourself in a situation which may or may not be true when you start having a condition itself, and this hot cold empathy bias where imagining yourself in a hospital setting may be very different when you're well and living fine in the community. It speaks a lot to people's preferences and values changing over time, and that affects desire to die, voluntary assisted dying pursuit. The other issues are around capacity, value, influence. I think now 12 months for neurodegenerative diseases in Victoria, I would say most, if not all, patients I've looked after with advanced Alzheimer's or other forms of dementia, the last 12 months, virtually most of them do not have decision-making capacity, much less to say a decision when it comes to voluntary assisted dying, where that's a big decision and a complex one to take on, understand, digest, and communicate what their wishes are. We've had numerous people in our palliative care unit, older persons who can no longer go home to live at home independently, and it's very sad to hear that some of them, when they do participate in various stages of their voluntary assisted dying journey, say that I would rather take my voluntary assisted dying substance now rather than go to a residential care facility. And as a clinician, we find it extremely hard to think in some way we're shaping or influencing them, saying that they can't stay in the ward any longer because they're so stable, but to get them moving to residential care might mean them taking their substance earlier. So we're navigating issues that we weren't navigating before. And it's a brave new world, I must say, and we're learning and reflecting and discussing that amongst teams, but also being candid and open with our families that often also have their own experience and belief systems that may or may not accord with the person themselves.
The other thing I'd like to say, John, I think there's definitely movement afoot already in Victoria to actually review the legislation and make some amendments. So I wouldn't be surprised if, I know dementia's not on the table at the moment, but I wouldn't be surprised if it is at some time in the future. Interestingly, one of my heroes in palliative care is an occupational therapist who's done a PhD on the role of rehabilitation in palliative care. And she's been looking at some of the emerging research around why people actually elect to use voluntary assisted dying and euthanasia, and particularly some of the research coming out of Canada that's been doing it longer than us. And actually the predominant reason that people elect to use VAD isn't necessarily things like unmanaged symptoms like pain or distress. It's usually around dignity issues. So when I can no longer actually toilet myself, when I can, when I'm actually dependent on other people to provide care for me, that's when I'm going to elect to use it. And so I think the unanswered question maybe in the dementia context from that is, how do we actually do dignity restoration for people with dementia? And we need to get more smart about those sorts of things, I think, too, enabling dignity restoration. I'm going to turn to the question up here. How can we best advocate for dementia patients who need access to palliative care? So yeah, you put in a referral. Hands up, how many people have put in a referral for a resident with dementia to palliative care, and palliative care have said, no, we can't see them? No hands? Oh, there's one hand. There's the second hand. I know that there's definitely the community teams that I've worked for that have occasionally had to say no, and said you're the primary healthcare provider, you need to have a palliative approach to your care for your residents. But opening that up to the panel.
I don't know how many people in the room know this, but aged care is funded by the Commonwealth and palliative care is funded by the state, and the two do not play very well together. One of the biggest challenges we get is we get comments from aged care services saying the palliative care service did this, and then we get the palliative care service saying we don't have the money to, we can't afford it, we don't have the resources, we don't have the staff. So what we can do is the bare minimum in this area because of this circumstance. Again, this goes back to tying the system together. We need to raise our voices of what we need in the sector for a start. If you do find your services are not being supported well, you have to let us know. You have to let your local members know. You have to let the health department know, because that's how we can actually have an argument to build up how to support aged care for a start. I think it also comes down to getting to know who your local palliative care service is. Each palliative care service operates within a set postcode and has their own model and their own set of staff, and with that they've all got their own way of working with aged care services. So to improve both quality of referrals you make to palliative care and to get better levels of engagement in terms of what they can give you in advice, it's good to know them, have a chat with them about what sort of residents are suitable for their service, what sort of support they're going to provide you in terms of if you did refer a resident, and what have you already got in place to complement what the palliative care service can do.
Can I add something there? I better take this little thing, my little talking stone. Yeah, I think I'll back up what Tiff just said. It depends on the quality of the referral. You've got to know exactly why you're referring this person. It's not about, oh, they've got dementia, automatically you go to palliative care. It's about what is it exactly that you want the palliative care team to do? And then backing up the idea that palliative care is core business in aged care. And if you're constantly struggling to deal with symptoms of your residents with dementia, it's also a problem for management to get you all better educated, and that's right, and better training, and that's what all these people here are. That's what Sam and I are here for. Like it is core business in your work, and so many people with dementia can be well managed by you guys because you're all doing it day after day. So I think the quality to really get clear about why you're referring the person to the palliative care team goes a long way for the pal care team, who are busy fielding referrals. They might get 10 referrals a week and they're flat out just trying to clear that backlog. And if you make it as easy as possible for them, then you're going to get a better result.
I think ambitiously what we'd like to see also is more deliberate rounding for palliative care into residential aged care, and there are some models out there. Calgary and Canberra, I know, developed NP rounding models into aged care. Goulburn Valley Hospice, they undertook a project rounding into aged care, which they have continued. Mario's the real champion there, so she's worth having a conversation with around that. So there are some innovative models about deliberate rounding too that we need to replicate across our region, I think. Next question. When is it timely to prescribe and have anticipatory medications for end-of-life care in dementia? That sounds like a doctor question.
True story. That's a good question. I think de-prescribing should occur at any stage of someone's serious illness journey, because I think we always need to be asking the question, are medications still benefiting the person at this stage or giving them more side effects? The question of anticipatory palliative care medications is a tricky one, because as you can remember the graphs, it is really tricky. They might look very sick, but they might come through the episode. And I have seen many times when palliative care medication should be on the chart overnight on the weekend, and it's not there, and it causes a lot of difficulty trying to secure those medications in a timely way. I have also been on the other side where it's being charted and not reviewed, and people getting it inappropriately, leading to delirium and falls as well. I think it needs to be, I think those models of care are very important, Steve, about needs rounds where we can plan proactively and pick out those signs when someone's starting to be on a deteriorating trajectory, especially weight loss. I find is a big thing. When an older person loses weight, that's usually a sign that time might be short. I think we just got to be mindful, those working in the home and community sector in aged care, that we should be asking ourselves, these medicines, should they be there or should they not be there? And speaking with the primary care providers or the treating specialists to review medications. Medications, as you know, is probably responsible for at least 16% of hospitalizations, and is the problem at almost half of the time during care transitions, either from hospital to home, home to hospital, hospital to residential care, and vice versa. So I think we need to take that seriously and make sure that things are charted in a timely way, but also have reviewing and monitoring processes in place to support good care.
I think I've seen those situations, Baron, where somebody has gone into a hospital, had an active delirium, they're put on multiple antipsychotics, they go back to the residential aged care facility and the medications are never reviewed again. Can you talk a little bit about anticholinergic burden and how that can make things worse, please?
Yeah, so anticholinergics are how some medications work and how they have got some medications that exert their activity. Anticholinergics are associated with falls, delirium, cognitive decline, constipation, urinary issues. So all the bad things that can possibly occur for an older person. And we know that the more medication someone has, the more likely they would have this, what we call an anticholinergic burden. Obvious medications like antidepressants, Parkinson's medication, bladder medications, those are very highly anticholinergic medications. But some of the lesser known ones like furosemide, diuretics, also have got anticholinergic activity. That's not to say, although as satisfying as it is whenever I see someone and reduce 10 medications to 5, the person's happy, they take less medications, they spend less money on it. We have to be very careful in what we can reduce and do it in a way that's we monitor carefully, because some things are there for good reasons, and if we take them off, they might decompensate or deteriorate from their heart failure or other conditions. So it needs to be careful, considered, balanced, and also we need to have good discussions with the person and your medical treatment decision maker about why we're doing that, the rationale, and what to look out for when we reduce medications, especially things that act on the brain, like antidepressants. They can often get withdrawal symptoms that might look like a delirium or depression itself coming back.
Great, thank you. Also, just on the end of life medications too, I think it's just really clear communication and really clear plans with the whole team around when they're utilised too. I think the experience that I had working with Kevin and Lisa in Yarrawonga, rounding into the aged care facility, is actually prescribing the end-of-life medications, but having clear conversations with the nursing team and the patient care assistants and so forth about the things to look for and the signs that may actually trigger the utilisation of those medications too. So the whole team's quite clear about that too. I'm just going to give a few seconds just for anyone to raise a hand before I go back up to the screen again. Any questions?
No.
Right. Who do we turn to support us talking about palliative care with our residents? So know your local teams, I think, is number one. Palliative Care Victoria do have a directory of palliative care services. So know who your local palliative care teams. I think Rose talked about that quite eloquently about making sure that your referrals are pretty clear about what you're actually asking for and what you would like reviewed. And somebody's just busting over there to tell us a little bit about...
Have you heard of Victorian Palliative Care Advice Service? Well, for those of you that have missed these 3 banners today, we are a statewide service that funds, same funding by all palliative care services across the state. It's one phone number, regardless whether you're a community member or a clinician. For community members, we're here to talk about what to think about and plan for, what palliative care actually means, linking in with local services where that is appropriate for district nursing, your GP, or for community healthcare services. And then for clinicians, we provide immediate support and advice for anything to do with clinical decision making, so symptom management plans, de-prescribing, converting medications. So if you call, you speak directly to a palliative care nurse, and in 35 seconds you'll be put through to a palliative care consultant. So that's really great for a lot of you who are out there with that burden of single point decision making and going, it's been a little while since I've done hydromorph, or it's been a little while since I've had to start a syringe driver, and are these medications correct? If you're erring, you can ring 365 days a year from 7 a.m. to 10 p.m. and speak and get some help immediately. No referral, get the information you need, and off you go again. If you haven't got any of these resources, please come and grab them, including the paint by numbers on how to put this into your policies and procedures that makes you compliant for aged care accreditation. It's easy. Not the quality. I do have 32 languages translated for community brochures, but not for the quality standards.
And I think Tiffany's got a response as well.
I just wanted to mention, so I know the new strengthening standards that having information for residents and families is now one of the big criteria. And I would argue you don't need external people to come have these conversations to your families. Families don't need the level of information that you have. They literally need the dot points and the brochures and books that you've seen on all the tables. If you have good knowledge of palliative care and what you offer in your service, you are the best person to be giving that talk. Because I can tell you all the questions you're going to get in that meeting are going to be, yeah, but what happens here when my mum needs palliative care? Who do you call? What did they do? And these are the questions that you have with families all the time. So empower yourselves. You can do this. Use Esther. You'll use all the resources, upskill your own knowledge, and you'll be able to have these conversations better than we do.
Don't forget Rose and Sam as well too, as conduits for accessing support and information and education as well too.
We've we've been running a series of communication workshops. Many of you may have come to them this year, and we've got one more at the end of the year, the 10th of December in Benalla. So don't miss it.
I think the other answer for me is just establishing those really key relationships. I'm sure Mario had that experience going into the residential aged care facility too. Like my phone, all the contacts that I've got are full of phone a friend, list of people. So those people that you can actually entrust with, I've got this situation, what do you reckon? So somebody who you can have what do you reckon conversations with too, I think is really important. How can we support younger people with dementia who are lucky enough to access aged care? Also those that cannot. Yes, that's a social justice question, I think. Anybody of the panel would like to tackle that curly one? You're throwing all the curly questions at us today. Any comments?
So this is a hot topic we get. Essentially, with the new Act, people under 65 aren't eligible for aged care funding and therefore go into the NDIS and therefore are restricted in access and residential care services, and it can be quite tricky. We get a lot of inquiries from people in the community, particularly people who are stuck in hospital, say in their 50s following a severe stroke, can't return home, don't have any family supports to accommodate a home care package, and they need residential care placement, and it's very difficult for them to find places that they can get appropriate funding and placement. This is an issue bigger than today. This is an issue that, again,
already.
You all know it. So yeah, sing along by all means, just relaxing. And thank you all so much for coming today, and I'm so proud of you all for the work that you're doing.
Very big thank you to Rose Sexton, Sam Morehouse. These guys are movers and shakers. They made it all happen.
Because I'm going to start this slide.
tumble and fall, and the mountains, they should crumble to the sea. I won't cry, no, I won't shed a tear, just as long as you stand by me. So darling, darling, stand by me, oh, stand by me, oh darling, won't you stand by me. Stand by.